Good morning, students. I'm Dr. Sucharitha from the Department of Dermatology. I'm an assistant professor. I'm going to take a class today on eczema. First, let us see the definition of eczema. Eczema in Greek means to boil over. It is an inflammatory condition of the skin. So it is characterized by erythema, papules, vesicles, oozing, crusting in the acute stages, and lichenification in chronic stages. This diagram shows the itch scratch cycle. What happens following following the itching sensation, the patient is scratched, and again it in turn gives rise to subsequent scratching. So this is the hallmark of most eczemas, the sensation of itch and the subsequent scratching. This is the hallmark of most eczemas. Now let us classify eczemas. Eczemas are classified into exogenous eczemas and endogenous eczemas. Exogenous eczemas are those that are related to external trigger factors, or they might also have some inherited tendencies. Whereas endogenous eczemas are mediated by internal factors, that is, they originate within the body. There are some eczemas which are caused both by endogenous factors as well as exogenous factors, about which we will discuss in the following slides. So the classification of eczema is endogenous eczema and exogenous eczema. Now let us see the classical features of endogenous eczema and exogenous eczema. In endogenous eczema, the lesions will be bilateral and there will be family history of atopic dermatitis and there can be seasonal aggravation. Whereas in exogenous eczema, the lesions will be unilateral at the site of exposure and you cannot elicit any family history of atopic dermatitis and there is no seasonal aggravation. Now let us see what are the eczemas which comes under exogenous eczemas and what are the dermatitis which comes under endogenous eczemas. Under exogenous eczemas, we have irritant dermatitis, allergic contact dermatitis, photodermatitis, dermatophytitis, and hand eczema. Under endogenous eczemas, we have atopic dermatitis, pityriasis alba, seborrheic dermatitis, discoid eczema, hand eczema, steatotic eczema, gravitational eczema, lichen simplex chronicus, and prurigo nodularis. Now let us see the clinical features of the various eczemas, it is common to both exogenous and endogenous eczemas. So the inflammatory developments of eczema involves three stages: acute eczematous inflammation, subacute eczema, and chronic eczema. So the clinical features vary for these three types of eczemas. And there is also another fourth stage, which is nothing but a post-inflammatory hyperpigmentation. So now let us see one by one what are the features which can be seen in acute eczema and what are the clinical features which will be seen in subacute and then in chronic eczema. So let us see one by one. Coming to acute eczema. Acute eczematous inflammation. The classical clinical features includes intense itching, erythema, which is also very intense, edema, papules, vesicles, oozing. All these things can be seen in a case of acute eczema. Examples are irritant contact dermatitis, heat eruptions, and pemphigus. So this image shows a acute eczema where you can see multiple vesicles, oozing, intense erythema, and the patient also had complaints of intense itching. Over the fingers here, you can see there are multiple vesicles, which is a classical sign of pemphigus. So this is an example of acute eczematous inflammation. That is the first stage of eczema. Now coming to the second stage, subacute eczematous inflammation. The clinical features of a subacute eczema are erythema again, but the erythema will be less intense when compared to the acute stage. There can be crusting, scaling, fissuring. The itching will be minimum to moderate, and there can also be stinging and burning sensation. So these clinical features are suggestive of subacute eczema. Now let us see a few examples of subacute eczema: steatotic eczema, atopic dermatitis, and eczematized tinea. All these things come under subacute eczema. So this is a classical picture showing the features of subacute eczema, where you can see minimal erythema, fissuring, scaling. So this comes under subacute eczema. This is an example of steatotic eczema. Now coming to the third stage, that is a chronic eczema, the clinical features include dry skin, excoriations, fissuring, and lichenification. So lichenification is the changes in the skin which is seen in the third stage of eczema. So the examples include lichen simplex chronicus, atopic dermatitis, and nummular eczema. This image shows there is lichenification in the skin, where you can see the skin is thickened and there is hyperpigmentation and there is exaggerated skin markings. So these three clinical features should be present in order to call as lichenified eczema. So there is something called autoeczematization, which is very important. It is also called as secondary dissemination. So what happens, any eczema, it has a tendency to spread far from its point of origin. This is called as secondary dissemination or autoeczematization. These secondary eczema lesions, they will be small, they will be papules or plaques, and they can be grouped papullovesicles. Once they will subside only when the primary lesion settles down, but it can also occur as a recurrence if the primary lesion relapses. So, secondary dissemination occurs at the site which is far away from the site of eczema, and once the primary eczema resolves, the secondary dissemination also resolves, and when the primary lesion relapses, the secondary lesions can also recur. That is a unique feature of autoeczematization. Now let us see a few points about atopic dermatitis. Atopic dermatitis is a rash that itches. There are many causes of atopic dermatitis. Any one particular cause cannot be pinpointed. It is a multifactorial, and there are also various immunological factors which play an important role in atopic dermatitis. And it also depends upon the phenotypic expression of the atopic dermatitis. Again, the atopic dermatitis has three clinical features. The three phases are infantile phase, childhood phase, and adult phase. Now, let us see one by one what happens during the infantile phase and what happens during the childhood phase, and how many percentage of the children will progress to adult phase. Now, coming to the infantile phase. Infantile phase starts during the weaning period of the newborn, and the classical symptom is itching. When the infant is a neonate, the nervous system will not be very well developed, so the baby will not have a coordinated movement of scratching. So the only clinical manifestation can be only an erythema, which will be bilateral and it will be present over the cheeks. So what will happen? This erythema will later progress into small papules within the erythema, and slowly the child will start rubbing the cheeks over the shoulders of the person who is carrying the child. So what will happen as a result? There will be abrasion, there will be oozing, there will be crusting, and there can be secondary bacterial infection. So these are the features of infantile phase. So this child is having erythema, papules, and scaling over the bilateral cheeks, which is the classical of infantile eczema. Now coming to the childhood phase, once the child begins to crawl, the site of involvement starts changing. Initially, over the extensor aspect of the elbow and the knees, the child will develop the lesions. But once the child starts walking, the flexural areas will start involving, like the cubital fossa, popliteal fossa, and the dorsum of the ankle. So the site of involvement starts evolving once the child starts walking. Again, there will be severe itching and scratching, and because of the loss of the skin epidermis or because of the abrasions, the child is more prone for frequent bacterial infections. So these are the clinical features of childhood phase. So this child, as you can see, there is erythema, papules, vesicles, abrasions, and excoriation involving the face. Now coming to the adult phase, in the adults, eczema will start involving limited areas, and lichenification will be a more prominent feature of adult phase. So the infantile phase will last for about 7 to 10 years, and the childhood phase will last for about 10 to 12 years. So this image is a good example of lichenification, where the skin is thick and pigmented and the skin markings are prominent. So this is lichenification, which you can see in the adult phase, and the site of involvement is a cubital fossa. So now let us see what are the complications of atopic eczema. As I said before, bacterial infections by Staphylococcus aureus, viruses like wart or molluscum contagiosum can occur over the site of lesions, and exfoliative dermatitis. The criteria which is used to diagnose atopic dermatitis is Hanifian and Raschka criteria. where there are major and minor criteria. Coming to the treatment aspect of atopic dermatitis, patient education is the first and foremost important, and bland emollients can be given. Topical steroids, in case of children, low potent topical steroids can be given. When there are secondary bacterial infections, antibiotics can be started. And as an alternative to topical steroids, topical calcineurin inhibitors like tacrolimus can be started. Now coming to nummular dermatitis. Nummular dermatitis is derived from the is given the name because of its discoid or oval lesions. The most common site of involvement is below the knee and elbow. It is mostly seen in girls when compared to the boys at the age of 12 to 15 years. And there is also a family history of atopicity. The differential diagnoses include dermatophyte infections, psoriasis, or any other exogenic contact dermatitis. Pityriasis alba. It is an endogenous eczema. It occurs in children between 5 and 15 years of age, and it is characterized by ill-defined hypopigmented dry patches with fine scaling present over the face. There are two types of pityriasis alba, facial pityriasis alba and extrafacial pityriasis alba. The differential diagnoses include pityriasis versicolor, early vitiligo, post-inflammatory hyperpigmentation, Hansen's disease, or any malnutritional skin manifestation. It is usually resistant to treatment. It is found that 0.1% of tacrolimus has been effective in the resolution of pityriasis alba along with moisturizers. So these images, they are showing nummular eczema. They are in the shape of a coin, hence the name nummular dermatitis or discoid eczema. You can see there are multiple papules, vesicles, and scaling and crusting oozing. These are nummular or discoid eczema. This image shows pityriasis alba, where you can see multiple hypopigmented scaly patches over the cheeks of a child, probably between 5 or 10 years of age. Now coming to asteatotic eczema. Asteatotic eczema occurs predominantly due to dry skin. Dry skin can occur in any individual because of the following reasons: diabetic state, hypothyroidism, chronic renal or liver diseases, dry winter seasons, or when it can occur in patients taking lipid lowering agents, oral hypoglycemic agents, and it is again characterized by itching, erythema, papules, vesicles, and plaques. It usually occurs in adults and old age groups, and mostly seen in lower limbs. This is a leg showing asteatotic eczema, where you can see scales, fissures present over the lower erythema present over the leg of an elderly person. Now coming to Pomphylix. Pomphylix is otherwise called as dyshydrosiform dermatitis. Pomphylix is characterized by deep-seated vesicles on the palms and soles or sides of the fingers. These vesicles sometimes they coalesce to form bulla, and then they tend to rupture. They'll be intensely pruritic. The differential diagnoses include trichophytids, erythema multiforme, and scabies. Pomphylix, there are two types of Pomphylix, Cheropomphylix and Podopomphylix. Cheropomphylix occurs over the palms and Podopomphylix occurs over the soles. Pomphylix can be both an exogenous as well as an endogenous eczema. So here you can see multiple erythematous, deep-seated vesicles. In few areas, they have coalesced to form bulla, present over the palms, sides of the fingers. This is dyshydrosiform Cheropomphylix. Now coming to seborrheic dermatitis. Seborrheic dermatitis, the most common sites involved are the seborrheic areas where there is a predominant of sebaceous glands like the scalp, face, eyebrows, nasolabial fold, retroauricular areas, front and back of the chest, axilla, and the pubic region. Seborrheic dermatitis is worse in summer. Sweating aggravates itching, and you can see papules, which is on scratching, they can form crust and infections. The scales are usually yellowish green, and treatment includes oral and topical antifungals. Oral tablet fluconazole can be given as 150 mg stat dose, and topically azoles can be given. For scalp, topical ketoconazole along with precipitated sulfur or salicylic acid can be given for adherent scales. Seborrheic dermatitis is a relapsing or remitting condition, and the patient will require treatment lifelong. So this is a image shows the involvement of the seborrheic areas in the face of an adult, where the T areas of the face, that is the area involving the above the eyebrows, the bridge of the nose, the paranasal areas, where you can see erythema, scales, papules, and crusting. Now coming to stasis eczema, which is otherwise called as gravitational eczema. Stasis or gravitational eczema occurs in individuals who have a prolonged history of standing. For example, people who are working in restaurants where they have to stand for several hours a day, or it can be seen in teachers where teachers or any people who have a history of prolonged standing. So what happens in the medial side of the legs, just above the medial malleolus, the stasis eczema will tend to occur, and the patient can also have chronic, they can have varicose veins, and this is because of the incomplete perforators, the perforators are unable to pump the blood from the lower limbs towards the heart. Hence, there is stasis of pooling of blood in the lower limbs, and which gives rise to itching, scratching, and further eczema. So the stockinette application throughout the day helps in pumping the blood from the lower limbs to the heart. So the patient is advised to use stockinettes throughout the day. This image shows stasis eczema around the medial malleolus, where you can see multiple papules, scaling, crusting over the medial malleolus. This is a case of gravitational eczema. So that's what we've seen about the endogenous eczemas. Now we can go to exogenous eczema. Irritant dermatitis is a type of exogenous eczema, where any irritant can come in contact with your skin and produce dermatitis. So it is a non-immunological inflammatory reaction which occurs due to the presence of an external agent. The presentations can be varied, and the types of irritant dermatitis are acute irritant contact dermatitis, chronic irritant contact dermatitis, transient, symptomatic, and pigmentary. This image shows acute irritant picture where there is a few vesicles erythema over the dorsum of the fingers. This is probably because of contact with the detergents. This is usually seen in women who spend most of the time in washing and cleaning using detergents. Next, coming to allergic contact dermatitis. Allergic contact dermatitis is a delayed type hypersensitivity reaction that occurs upon contact of the skin with an allergen. This inflammatory reaction follows the absorption of antigen which is applied to the skin, which has been priorly sensitized. So it develops within 12 to 48 hours of antigen exposure, and it can persist for about 3 to 4 weeks. Here you can see the buckle of the pant has caused this allergic contact dermatitis in the area where it has come in contact with the skin. This is an example of allergic contact dermatitis where you can see an ill-defined block with vesicles, papules, excoriation, and crusting. Here you can see the metal of the glass, the frame has produced in contact dermatitis. You can see the area of involvement of the lesions. Wherever the frame has come in contact with the skin, the patient has developed these lesions. So this is a classical example of allergic contact dermatitis. This is probably because of the metal nickel. Now let us see the differences between allergic contact dermatitis and irritant contact dermatitis. Allergic contact dermatitis takes about 7 to 10 days for the reaction to occur, whereas irritant contact dermatitis occurs immediately following the contact. Allergic contact dermatitis can occur at the site as well as away from the site of the contact, whereas irritant contact dermatitis occurs only at the site of the contact. Allergic contact dermatitis is ill-defined, whereas irritant is well-defined. Itching is a predominant symptom of ACD, whereas burning, stinging, pain, or soreness is a predominant symptom of ICD. In allergic contact dermatitis, there can be intense vesiculation, whereas in ICD, you can have erythema, edema, vesiculation with bulla formation, and even necrosis can occur because of the irritant nature of the contact. Now coming to photodermatitis. Photodermatitis is an eczematous response of the skin to sunlight. So it is otherwise called as photosensitive eczema. It typically appears over the light exposed areas of the skin. There are many types of reactions to sunlight: phototoxic reaction, photoallergic reaction, and eczematous polymorphic light eruption. Now let us see a few points about phototoxic and photoallergic reactions. There are some drugs which can be either in the form of topical or as a systemic, some chemicals and some allergens. When they combine with UVA spectrum, they produce some phototoxic and photoallergic reactions. The phototoxic reactions are very common, whereas photoallergic reactions are less common. Phototoxic reactions are non-immunological, whereas photoallergic reactions involve a type 4 hypersensitivity. Phototoxic reactions occurs due to a sunburn, whereas photoallergic contact dermatitis appears as an eczema. Phototoxic reactions are diagnosed clinically, whereas photoallergic contact dermatitis can be diagnosed only with the form of patch testing. A patch testing should be done to confirm that there is a photoallergic contact dermatitis. Here you can see the sun has produced a phototoxic reaction. It has typically appeared over the V area of the neck where there will be exposed to sunlight. Now coming to the photoallergic reactions, Parthenium induces photoallergic dermatitis. It is a type of hypersensitivity reaction which is aggravated by sunlight. It is commonly seen in people who come in contact with the pollen grains and other parts of the plant, Parthenium hysterophorus. It is usually occurs in farmers and it occurs in people who live in the vicinity of these plants. These plants are usually found near the railway tracks. So people living near the railway tracks are more prone for developing this Parthenium-induced photoallergic contact dermatitis. So this man has developed a allergic contact dermatitis to Parthenium. This is a plant which is a Parthenium hysterophorus. You can see the entire skin of the face is edematous, thickened. There is a loss of nasolabial fold. There are deep furrows over the forehead. And this is a classical example of Parthenium-induced photoallergic contact dermatitis. Now, how to diagnose a case of photoallergic contact dermatitis? As I previously said, a patch testing is mandatory for the diagnosis to confirm the diagnosis in suspected case of allergic contact dermatitis. So some eczemas who have an atypical presentation or an asymmetrical distributions can be subjected to patch testing. In order to detect the external allergen, when the eczema does not respond to treatment. So these are the following indications where a patch testing can be done. One is to confirm the diagnosis. The next one, when the eczema has an atypical presentation or an asymmetrical distribution. The third is eczemas who do not respond to treatment. So in all these conditions, patch testing is indicated. Sensitization to topical medicaments. That is one of the example of patch testing. This is the back of the patient who has been applied the 40 allergens and the tapes have been stuck over each of the allergen. And this is observed after 48 hours. And the allergen which causes the contact dermatitis can be identified in the back of this patient. The patient should be advised not to bath for another 2 days and report to the OPD after 48 hours in order to find out which allergen has been causing the contact dermatitis, allergic contact dermatitis. How will you manage a case of allergic contact dermatitis? Emollients can be used frequently to deal with the dryness of the eczema, and the patient should be asked to avoid any known allergens or irritants. Topical steroids are the mainstay of treatment. When the disease is very severe, we can also go for systemic corticosteroids. Antihistamines are usually given for the management of eczemas because of the intense itching which is associated with eczemas. And the antihistamines can be sedative antihistamines. And a broad spectrum antibiotics can also be given when there is a secondary bacterial infection. So the treatment is tailored to the need of the patient. There is not one single treatment which is common to all. Coming to the topical treatments of eczemas, during the acute stage where there is itching, oozing, the compresses can be given. A Condy's lotion or saline compresses can be given. Burroughs solution can also be applied. Calamine lotion can be applied, which acts as a hygroscopic and then it will absorb and it will make the lesion dry. Calamine lotion. For subacute cases, ointments can be given. In the steroid ointments or creams can be given. Zinc oxide can also be given. For chronic lesions, chronic eczemas, steroids, high potent steroids under occlusion can be given. Even intralesional steroids can be given when there is lichenification. Phototherapy, emollients, sunscreens in cases of photosensitive eczemas, and topical immunomodulators such as tacrolimus and pimecrolimus. All these can be given in patients with chronic eczema. What are the systemic treatments in the systemic treatments for eczema? Antibiotics in cases of secondary bacterial infection, antihistamines, even oral steroids. tranquilizers to calm the patient, and immunosuppressants, immunomodulators can also be given like methotrexate, cyclosporin, and UVA therapy. It's nothing but a phototherapy with Soralen. All these treatments have been tried with success in the treatment of eczema. So we have reached the end of the class. So I would like to give a quick revision of all those things which we came through, which we came through in this class. So eczema is nothing but a which means to boil over in Greek. There are two types of eczemas: exogenous and endogenous eczemas. Exogenous eczemas there are a few differences between exogenous and endogenous eczemas. Exogenous eczemas and endogenous eczemas, these are the differences between them. And the exogenous eczemas includes all these things, and the endogenous eczemas includes all these atopic dermatitis and pityriasis alba, seborrheic dermatitis. The most common ones are atopic dermatitis, pityriasis alba, and seborrheic dermatitis. So these are the three phases of eczemas: acute, subacute, and chronic. And each stage have different clinical features. So during the acute phase, there will be itching, erythema, edema, papular sickles, and oozing. So this is a classical example of acute eczema. And this is the clinical features of subacute eczema, where there will be crusting, stinging, or burning sensation. And these are the clinical features of chronic eczema, where you can see lichenification, skin thickening, pigmentation, and prominent skin markings. And autoeczematization is a very important thing which can occur in eczemas, where, as I told you, there will be papules away from the site of the lesion, and it will resolve once the primary lesion is treated. About atopic dermatitis, there are three phases: infantile, childhood, and adult phase. So we saw that what are the sites of involvement of infantile phase, that is the cheeks, and what are the sites of involvement of the childhood phase, which is nothing but the extensors, because the child starts crawling, and in the adult phase, flexures starts involving. This is an example of atopic dermatitis over the cubital fossa. These are the complications: bacterial infections, exfoliative dermatitis, nummular eczema, discoid coin-shaped eczemas present over the lower limbs, that is called nummular eczema. This is pityriasis alba, ill-defined hypopigmented patches over the face. Coming to astiotic eczema, it occurs in elderly patients where there is extreme dryness of the skin due to hypothyroidism or diabetes or consumption of lipid-lowering agents. So the skin becomes dry. It produces a crazy pavement appearance. There are fissures, there is scaling, there is erythema. This is because of cooling of the blood in the lower limbs and because of the incompetent perforators. Pemphigus is a type of both exogenous and endogenous eczema. Produces deep-seated vesicles over the palms and soles. Here you can see multiple deep-seated vesicles. This is called a sago grain appearance. Coming to seborrheic dermatitis, where you can see erythema, vesicles, papules, scaling over the seborrheic areas. That is the T area of the face, nasolabial fold, eyelids. When it involves eyelids, it is called as blepharitis. Coming to stasis eczema or gravitational eczema, where there is stasis of the blood and which produces eczema around the medial malleolus. The exogenous eczemas are predominantly irritant contact dermatitis and allergic contact dermatitis. Irritant contact dermatitis occurs at the site of contact, whereas allergic contact dermatitis occurs at the site, occurs away from the site of contact. Here you can see the place where there is a contact of the metal of the skin, the patient has produced lesions. So these are differences. This is a photosensitive eczema. This is a Parthenium plant which produces Parthenium photoallergic contact dermatitis. Patch test. Now coming to the question as pityriasis alba is a manifestation of which eczema? It is an endogenous eczema. Pityriasis alba is an endogenous eczema. Housewife's eczema is a form of both irritant contact dermatitis, allergic contact dermatitis, infective eczema. So the answer is all of the above. Grains of moiled sago are seen in pemphigus, sago grain appearance, where there will be deep-seated vesicles in the palms and soles. So grains of boiled sago is a characteristic of pemphigus. Crazy paving pattern is seen in eczema craquelle or astiotic eczema, dry skin eczema. Eczemas which can lead to erythroderma are all except nummular dermatitis. Atopic dermatitis can cause erythroderma. Seborrheic dermatitis can cause erythroderma. Phytophotocontact dermatitis can cause erythroderma. The only dermatitis which cannot progress to erythroderma is a nummular dermatitis. Window glass blocks all of the following rays except it blocks which of the following rays? It blocks UVC. It does not block UVA or UVB visible light. It blocks only UVC, which is nothing but a carcinogenic. UVC is carcinogenic. A 45-year-old alcoholic patient presenting with erythematous to hyperpigmented scaly blocks over the bilateral hands and feet of 3 weeks duration. There is a clear demarcation between the involved and uninvolved skin. What is the likely diagnosis? The diagnosis is pellagra. It is because of it is a nutritional dermatosis. Pellagra. Name of physical sunscreen: zinc oxide, titanium dioxide, ferric oxide. These are the few physical sunscreens. Zinc oxide, they all are physical sunscreens. Physical sunscreens, they act by blocking the UV rays from entering your skin. They do not alter the UV rays and they just block the UV rays from entering your skin. So finally, all eczema is dermatitis, but all dermatitis are not eczemas. Thank you.